Welcome to CFRI's Cystic Fibrosis Community Voices, a video podcast series created by and for the cystic fibrosis community.
Hello, my name is Ari Naaman, and I'm here today to talk with you about how the quality-adjusted life year, or QALY, harms people with cystic fibrosis. I'd like to thank CFRI for inviting me to talk with you. Before we begin, let me just share a little bit about myself. I'm here today in my capacity as a consultant to the Partnership to Improve Patient Care, a coalition of advocacy groups working to ensure value assessment is fair and non-discriminatory for people with disabilities. Prior to that, I co-founded and ran the Autistic Self-Advocacy Network and served as one of President Obama's appointees to the National Council on Disability. And I also currently serve as a visiting scholar at the Laurie Institute for Disability Policy at Brandeis University, and as a PhD student in health policy at Harvard, although those are not the capacities in which I'm talking to you today. Let's start by talking a little bit about what the QALY, or Quality Adjusted Life Year, is. So the QALY is designed to be a measure of the burden of a particular disease, disability, or diagnosis, and the effectiveness of a particular healthcare intervention in mitigating or treating it. In principle, one QALY is supposed to equal a year in perfect, non-disabled health, whereas a QALY score of 0 constitutes death. In general, most conditions are assigned a value between 0 and 1, reflecting disabled or sick life. Now you can see here that different conditions, and this is just a representative example, we're going to refer to some specific QALY scores later on, are ranked at different levels between, again, death and perfect, hypothetical, non-disabled health. Now, why are we talking about the QALY? Well, as some of you may be aware, there is an ongoing conversation on the part of many payers, insurance companies, state Medicaid agencies, other entities that pay for healthcare, as to whether and on what terms to cover some of the new medications available to treat cystic fibrosis, as well as other conditions and disabilities that require high-cost medical interventions. Over the course of the last 20 years, there has been a growing focus on cost containment, not just in the United States, but internationally. For at least 2 decades now, the United Kingdom has utilized the Quality Adjusted Life Year to make decisions about what healthcare interventions will and will not be covered within their healthcare system. And we're now seeing some proposals to adopt the Quality Adjusted Life Year in the United States as well. In particular, there's a group called the Institute for Clinical and Economic Review, or ICER for short, that has been funded to conduct QALY-based value assessments on each new drug that comes to market in order to make recommendations as to how valuable that drug is, and implicitly and sometimes explicitly, whether or not payers should cover it. And we've already seen this come up in the context of several of the prior cystic fibrosis drugs, such as Orkambi and Kalydeco. ICER has been growing in prominence. They announced several years ago a partnership with the Veterans Administration that has been informing the VA's formulary decisions. They announced about 2 years ago a partnership with CVS Health, one of the country's largest pharmaceutical benefit managers, that indicated they would not cover drugs, that they would offer employers an opportunity not to cover drugs that did not meet a $100,000 per QALY threshold and did not qualify for the FDA's breakthrough therapy drug designation. And ICER's analyses, based on the quality adjusted life year, have also been used by a number of other payers, including recently the state of New York's Medicaid agency, to call into question either whether or not cystic fibrosis drugs will be covered, or whether or not they will be made available without tight utilization management restrictions, such as step therapy or fail first protocols, very robust prior authorization requirements, and other restrictions that can make it very difficult for people with cystic fibrosis and people with other disabilities or chronic conditions to access the care they need. So this is increasingly important. And part of the reason why we're having this conversation is because there are a number of problems with the quality adjusted life year. And these problems are having an increasing impact on the cystic fibrosis community. Later this week, the Institute for Clinical and Economic Review, we'll call them ICER, somehow most people refer to them from here on in. ICER is going to be releasing a draft evidence report on Trikafta, a new medication for cystic fibrosis that I think many of you are already familiar with. It's been having a very positive impact on many people with cystic fibrosis throughout the country and throughout the world. And so when we're talking about the quality adjusted life year as the measure that may determine whether or not people have access to these drugs and under what terms and with how much bureaucracy and how much ease of access, it becomes very important to know that that measure is non-discriminatory and is fair for people with disabilities. And unfortunately, the QALY does not meet that bar for reasons we'll be talking about on this webinar. So we're going to go through 4 concerns that disability rights activists have with the quality adjusted life year. The first is a very long-standing, very familiar concern that has been raised by disability rights activists for as long as the QALY has been in use. Namely, that under QALY-based systems, extending the lives of people with disabilities is worth less than extending the lives of people without disabilities. What do I mean by that? Well, I think it would be helpful if we got into some specifics. Remember that broad series of hypothetical examples of different health states ranked between 0, representing death, and 1, reflecting perfect health? Well, where does cystic fibrosis fit into that? These are the utility scores used by ICER for their assessment of the value of cystic fibrosis medication. And one of the things you see very immediately is that life with cystic fibrosis, a year in the life of a person with a cystic fibrosis, is heavily discounted the more severe their condition is. So what this reflects here, and the ppFEV1 clinical measure is used to reflect different health states for people with cystic fibrosis, is that a ppFEV1 score of above 90% implies that a year in the life of a person with cystic fibrosis with that ppFEV1 score is worth approximately 92% of a year of hypothetical perfect non-disabled health. And as the ppFEV1 score grows lower, for example, if we were to jump down to between 60 and 69, the utility or value ascribed to a year in the life of that person becomes progressively lower. At 60 to 69, a year in the life of a person with cystic fibrosis at that ppFEV1 score is considered to only be worth 80.1% of a year in the life of someone in perfect non-disabled health. We go lower still, we see at 20 to 29 ppFEV1, year in the life of a person with cystic fibrosis at that ppFEV1 score is considered to be worth only 0.653 or 65.3% of a year in the life of someone in perfect non-disabled health. And there's some very real concerns that materialize as a result of that. I mentioned that these are the utility scores that ICER is going to be using in their analysis of Trikafta and has already used in their analysis of previous cystic fibrosis medications. And this is also from ICER's analyses of cystic fibrosis drugs. And one of the things you see here is you can look and see some of the information on how different drugs score in terms of the average number of pulmonary exacerbations that people with different types of cystic fibrosis on different drugs have. The total number of life years, the expected lifespan that people live on these different drugs, and the total QALY score that people have on these different drugs. And you can see very clearly that the total life years and total QALY score here are actually very different numbers. And the reason why you have under Kalidco plus best supportive care, 26.52 life years, but only 22.65 QALYs is, again, each of these life years is discounted based on these previous utilities that reflect what a year in the life of a person with cystic fibrosis in different health states is supposed to be worth. And so there are some very real concerns that people with disabilities have that the QALY, by discounting the value of the lives of people with disabilities, may be discriminating against people with disabilities because extending the life of someone in a worse health state is considered less valuable than extending the life of someone in a better health state. And this is particularly relevant for people with cystic fibrosis and other chronic conditions that are not likely to be cured as a result of healthcare interventions. The QALY isn't necessarily a huge problem if you have a condition that is restored to perfect health, although for a great many conditions that's not the case, and there are other potential issues in value assessment that need to be discussed even for those conditions. But if you have a chronic condition that isn't going to go away, that is going to require, like cystic fibrosis, ongoing management and treatment throughout your life, then it really does represent a severe problem that the value of life extension for you is discounted over the course of, as a result of the use of the quality adjusted life year. So you might ask, how did we arrive at these numbers? How did ICER arrive at these numbers? So we're going to talk a little bit about the process through which these particular utility values, these discounts on the value of life with cystic fibrosis are determined, and some of the concerns that exist with regards to that process and how it may be biased in ways that don't really account for the nuances or complexities of disabled life. So there are a variety of means that these numbers are come to by, but two of the most common are what's referred to as the time trade-off method or the standard gamble and the standard gamble. And basically each of these consist of surveying large numbers of members of the general population, so mostly people without disabilities, and asking questions like, would you rather have 10 years of life in a wheelchair or 5 years of life in perfect health? And if people are approximately indifferent to those two options, then a conclusion is reached that a year of life in a wheelchair is worth approximately 50% of a year of life in perfect health. Similarly, under the standard gamble method, people are asked if you had a particular disability, let's say you were severely depressed and you were offered a surgery that had a certain likelihood of killing you and a certain likelihood of perfectly curing your depression. For what likelihoods would you agree to take the surgery? And you can see here that these questions, especially asked to the general public, most of whom have not necessarily had the experience of life in a wheelchair, or life with severe depression, or life with cystic fibrosis, might not be the best way to figure out what the realities of living with those conditions are. And that also, that for most people with disabilities don't think of their conditions in terms of something that they would trade years of life in order to get rid of. Most people with disabilities instead are pursuing both life extension and the opportunity to improve their functional states and be healthier. So there's usually, for most people with disabilities, those two goals are not perceived to be in conflict. And when you go to your doctor, you generally are looking for an opportunity both to live longer and to be healthier. And so that doesn't really reflect the realities of how people with disabilities think about their own conditions. Now, the average member of the general public has never heard of cystic fibrosis. Or if they have only the most limited idea of what a year of life with cystic fibrosis is like. I can assure you they do not know what ppFEV1 is. And so you might ask, how can you ask members of the public to answer these questions with regards to cystic fibrosis, or really any number of the hundreds or thousands of different diagnoses and health states within those diagnoses out there? And that brings me to another problem that exists with the quality adjusted life year. Namely, that the process of translating clinical outcomes, which are reflected often using very sophisticated tools designed for particular conditions, into this simple QALY score of between 0 and 1, results in a significant loss of information. So let's talk a little bit about how the public is asked these questions. This is the EQ5D, 5L. It's actually the most recent iteration of the EQ5D. I'll talk a little bit about what that means in a moment. The EQ5D is the most commonly used tool for assessing health-related quality of life. There are a couple of other tools out there that are used, but they're fundamentally similar to the EQ5D. Essentially, what the EQ5D does is it asks 5 questions one about mobility, one about self-care, one about usual activities, a lot of stuff mushed together there, one about pain slash discomfort, and one about anxiety slash depression. Again, not necessarily something we usually think of as mushed together like that. And for each of these 5 questions, there are 5 different health states. For example, with regards to mobility, an individual can answer, I have no problems in walking about. I have slight problems in walking about. I have moderate problems in walking about. I have severe problems in walking about. Or I am unable to walk about. That's a pretty simplistic framework, especially when you take into account that this is actually only the most recent version of the EQ5D. For most of the EQ5D's history, it's actually only offered 3 answers to each of these questions. But even with 5, that really loses a lot of the nuances of life with a mobility impairment. Just like each of these questions really struggle to capture the realities of disabled living. Now, why are we using this very simplistic tool? Well, the big reason why this is utilized is because it is very easy for people who receive a phone call or are otherwise being surveyed and who are members of the general public and don't have a lot of specific content area knowledge with regards to life with cystic fibrosis or life with depression or life being a wheelchair user or life being blind or life being deaf, to answer these questions and to understand these different health states, even if they don't really equate to the lived experiences of people with disabilities. So what does this mean in practice? Well, remember we talked about the different ways in which these questions are asked. Well, what is done with these responses from these surveys of the general public? This Excel spreadsheet reflects the different health states and the values assigned to them in different countries based on these telephone surveys of the general public. And remember, we have these 5 questions, so we can score each of them 1 through 5. And so over here, under 5L profile, you can see what is the value in your country of a year in your life, depending on how you respond to these 5 EQ5D questions. Now, of course, the best possible response is 1s across the board. It means you consider yourself in perfect non-disabled health on each of these 5 domains. That means you get, in the United States, a QALY score of 1. Now, let's scroll down a little bit. In fact, we don't even have to scroll down that much. Let's say that you indicate a 4 on just the last question, which we can see here is regarding anxiety and depression. That means in the United States, your life is now considered to be worth approximately 30% less. So approximately 70% of a year of non-disabled perfect health. A year in your life is considered to be worth 70% of a year in the life of a perfectly healthy non-disabled person. This has some very concerning ethical implications. In fact, I would argue that while this is a horrendously bad tool to be used to value the lives of people with disabilities and people with chronic conditions, it is in some ways a very useful tool for understanding the relative fears and biases that the general public has with regards to different kinds of disabilities and impairments. And in fact, you can see all kinds of very interesting things on how the index score changes based on the responses. We've loaded here the United States' survey responses. So let's look at how the score changes. We just went from 1 to 0.442 because I moved mobility to 5. We lost about 56% of the value of the life of a hypothetical person who's unable to walk. And now we're bringing them back up to 1. And we can then go to usual activities, which perhaps people understand a little bit less than they understand mobility. And now we see we've moved that to 5, and now we see we're at 0.626. So it's about 38% of the value of a year in the life of this hypothetical person is lost as a result of moving their usual activity score to the lowest rung. So this is really concerning at a practical level for the reasons we talked about earlier regarding how this might result in us undervaluing intervention that might extend the life of someone with a disability that is not going to be cured by that intervention, but will live longer as a result of that intervention. But it's also very concerning because, again, the EQ5D, these 5 questions, are a very, very, very simplistic way of understanding life with a disability. So let's compare the EQ5D to another tool for assessing quality of life that's actually designed specifically for people with cystic fibrosis. These are some sample questions. It's actually a very long tool, so there are only some of the sample questions from the Cystic Fibrosis Questionnaire Revised, the CFQR. And one of the things you immediately see here is we're talking about a much more granular, much more specific way of talking about life with cystic fibrosis. These questions, which are from the respiratory section of the CFQR, are really allow people to communicate information about their experiences with a much higher degree of specificity than the EQ5D allows them to do. They let you go into different aspects of some of the respiratory challenges that people with cystic fibrosis have. If you look at other aspects of the CFQR, because it's not just about respiration, they also look at other activities that people might want to do. And again, this reflects the fact that this is an instrument that was developed specifically for people with cystic fibrosis. This is something that was designed with people with cystic fibrosis in mind. And so it's a much more sensitive, much more nuanced tool that's much more likely to account for the realities of life with cystic fibrosis than anything the EQ5D or the larger QALY framework could accomplish. So let's ask ourselves the question then, okay, why with a tool like the CFQR, which has a lot more questions than this, we can't go through the whole CFQR, we'd be here for far longer than we have, are we using this very simplistic representation of life with cystic fibrosis that again is focused on measuring in ICER's analysis solely by ppFEV1, which has some other problems that we'll talk about later. And again, it really forces everything into that 0 to 1 QALY scale. Well, in order to answer that, there are 2 things I'd like to point out. First, you might ask, where did ICER get the ability to tie these utility scores, which again were taken from surveys of the general public and attached to the EQ5D, those 5 questions, and attach them to the ppFEV1 clinical measure for cystic fibrosis. So we spent some time looking through ICER's evidence report for cystic fibrosis, and we traced back to, I believe, the study ICER used in order to map ppFEV1 scores to particular utility states under the QALY scale through the EQ5D. It's a study from the United Kingdom. It consisted of 94 people with cystic fibrosis who were asked to fill out the EQ5D. Information on their ppFEV1 scores were taken by a clinic. And then based on those responses from 94 people with cystic fibrosis, health policy recommendations are being made in the United States and potentially all around the world on how to value the life of people with cystic fibrosis, correlated to, again, particular scores on the EQ5D. So that's concerning in and of itself. Do we know that those particular 94 people with cystic fibrosis have the same sets of preferences or the same sets of health experiences as other people with cystic fibrosis? It's hard to say. Why were these 94 people in this particular study utilized? Well, that's what ICER had available to them. And they would say, well, it's the best we can do, so it's good enough. I think we would disagree with that. In addition to that, you might wonder, why are we still using the EQ5D? Why are we using the EQ5D in the QALY at all? After all, we have this beautiful CFQR instrument instead that reflects a much more nuanced understanding of quality of life for people with cystic fibrosis. And in fact, if we look at this study, it's Bradley et al. Study, the same 94 people who filled out the EQ5D also filled out the CFQR. So why don't we use the CFQR instead? The reason is that ICER and other proponents of the QALY are very invested in the idea that they can make comparisons about the value of the year in the life of people with wholly different conditions that are measured in wholly different ways. ICER and other proponents of the QALY believe that the QALY lets them have a common scale that lets you measure the effectiveness of cystic fibrosis drugs against depression drugs, against cancer drugs, against Parkinson drugs. And in order to do that, they feel that the QALY will let them ask the question, what's better? A year in the life of a person with this particular type of cystic fibrosis and ppFEV1 score, or a year in the life of a person with this particular kind of muscular dystrophy. I'll show you what I mean. This is from a catalog of EQ5D-based QALY scores that reflect different conditions across the broad scale of diagnoses. I'm just going to show you a couple of them here. So you can see here, the first number in this column is, I believe it's the number of people, it's the number of patients in the sample that was used to get the EQ5D score. I'm going to jump a few numbers down. This column over here is the EQ5D score associated with particular conditions. So let's go down to, let's use attention deficit hyperactivity disorder, ADHD, from 18 to 24 years. So a young adult with ADHD. According to the EQ5D QALY score, which is really the basis for ICER's analyses, a year in the life of a young adult with a year in the life of a young adult with ADHD has a QALY score of 0.8, which is approximately equivalent to a year in the life of a person with cystic fibrosis with a ppFEV1 score of between 60 and 69. Does that seem like a little bit of a nonsensical comparison to you? I would agree. Similarly, let's look at some other EQ5D scores. So here we have the EQ5D scores for multiple sclerosis. And just as the ppFEV1 clinical measure is utilized to map particular health states in cystic fibrosis to particular QALY scores in multiple sclerosis, the EDSS, or Enhanced Disability Status Scale, is utilized. And again, you can see different EDSS scores equate to particular QALY scores. So again, now let's look at EDSS 2.71, which is approximately equivalent to between 40 and 49 on ppFEV1 in cystic fibrosis. Again, what ICER is trying to do is to have a comprehensive yardstick in which it can stick us all on, even if we have very different diagnoses, very different types of disabilities, very different measures of impairment, very different nuances to our particular condition. And you start to see now why the EQ5D is so simplified, because they want a measure that can be used to capture information on every disability and every diagnosis and compare them. And the problem with such a broad generic measure is that it really loses nuance. You cannot ask complex, nuanced questions around different aspects of life with cystic fibrosis if you are trying to have this very simple measure that you can apply to every condition in the universe. And because of that, at each of the different stages of translating a condition-specific measure, like the ppFEV1 or the EDSS in multiple sclerosis, into a QALY score, you lose information. And that loss of information may be very significant because that information may be a big part of why people are deriving value from a particular drug. That information may speak to a loss of particular side effects. In the mental health community, there are many folks who are concerned that value assessment in the context of psychiatric medication is not accounting for drugs that mitigate or do away with some of the serious side effects that have long been associated with particular psychiatric medications. In the context of cystic fibrosis, there are a variety of aspects of life with cystic fibrosis that even ppFEV1, let alone the QALY and the EQ5D, don't fully account for. So the fact that we're losing this information really presents some very serious concerns, because it means that the mathematical model that ICER is using to decide what the maximum price should be for a particular drug, and as a result, whether or not payers, insurance companies, and other similar entities should cover it, or whether or not they should cover it without some pretty heavy utilization management, bureaucratic restrictions on access to care, is really not accounting for the complexities and nuances of the lives of people with cystic fibrosis or the lives of other people with disabilities and chronic conditions that are subject to this means of value assessment. Let's move on to two other areas where there are concerns with the quality adjusted life year. So you might ask, okay, you have these problems with the EQ5D. You're concerned about surveying the general public, calling them up on the phone in the middle of their dinner and asking them, would you rather have 8 years of life in a wheelchair or 4 years of life in perfect health, or will you take the surgery? Here's the chance it's going to kill you. You just don't think that that's a good way to get access to information about how people value their life experiences with and without a disability. I would agree with you. So why not just ask people with disabilities themselves how many years of life they would trade or how they value their lives? Well, there are some serious concerns with that as well, because remember, the QALY isn't just a tool to measure life extension. It's also supposed to be a tool to measure quality of life improvement. And remember, that's what we were supposed to be getting at when we mapped particular PPFEV1 scores onto particular QALY scores. QALY is supposed to combine in one number both life extension and quality of life improvements. And so you end up with a very concerning dynamic that some ethicists refer to as the QALY trap. I'm going to show you an example of that. This is a quote from Peter Singer, who's a very prominent bioethicist with a number of very concerning views with regards to people with disabilities. It's a much longer conversation. This was published in the New York Times, I believe about 11, 12 years ago now. My goodness, I'm getting old. I remember when this came out. I'm just going to highlight a couple of components of this quote, this argument from Peter Singer, which is a fairly common argument we see from a number of bioethicists who defend the use of the quality-adjusted life year. Disability advocates, quote, this is Singer now, disability advocates might argue that such judgments made by people without disabilities merely reflect the ignorance and prejudice of people with disabilities when they think about people with disabilities. We should, they will very reasonably say, ask quadriplegics themselves to evaluate life with quadriplegia. If we do that and we find that quadriplegics would not give up even 1 year of life as a quadriplegic in order to have their disability cured, then the QALY method does not justify giving preference to procedures that extend the lives of people without disabilities over procedures that extend the lives of people with disabilities. So far, so good. But here's the catch. Again, quoting Singer, this method of preserving our belief that everyone has an equal right to life is, however, a double-edged sword. If life with quadriplegia is as good as life without it, there is no health benefit to be gained by curing it. And this is, again, one of the other problems that we see with relying on the QALY, which, again, combines quality of life and life extension, two things that people want and really generally do not see as in competition with each other, into a single number. And for people with disabilities and chronic conditions, basically asks to prioritize one or the other. If you assess the value of your life as equal to that of a non-disabled person, then under the QALY method, you cannot attach any value to an intervention that will improve your quality of life. This is actually a pretty serious concern for people with cystic fibrosis, because actually when we survey people with cystic fibrosis we ask questions around valuing their quality of life, they generally rate their quality of life as pretty high relative to a year in perfect non-disabled health. In the United Kingdom's assessment of ORCAMBI, this came up, it's referred to as a ceiling effect, and Vertex in their negotiations with the United Kingdom noted that people in their clinical trials had a very high baseline EQ5D score because they're born with cystic fibrosis, and so they perceive their quality of life to be normal, equivalent to people without cystic fibrosis. They consider their lives as having equal value. But because they consider their lives as approximately equivalent to the lives of people without cystic fibrosis, it then becomes very difficult under a QALY-based system to score quality of life improvements from Orkambi, Kalydeco, or very soon Trikafta, or any other cystic fibrosis drug, as providing any quality of life improvement for people with cystic fibrosis, because you cannot have a QALY score above 1. You cannot see your life, your quality of life under this measure improve beyond that ceiling that is supposed to reflect perfect non-disabled health. So that means that in clinical trials of cystic fibrosis drugs, one of the things that we see emerge is there are often statistically significant differences between the effect of a drug and placebo when using the CFQR, which is again a much more sensitive measure, in this case the CFQR respiratory domain, a much more sensitive measure because it's specifically organized around the life experiences and needs of people with cystic fibrosis, than we see with regards to the EQ5D or the QALY. And so again, we're really losing information here because we're insisting on the use of this very simplistic QALY method that doesn't account for the different life experiences of people with cystic fibrosis. I'm just gonna share a quote from a good friend of mine. Actually, one of the reasons I got into doing work around value assessment and specifically the disability rights critique in value assessment are some of the concerns this friend shared with me about how ICER and similar efforts may make it more difficult for her to access the medication and healthcare that she needs. This is what she said to me when I shared with her that we were going to be doing this webinar and talked a little bit about some of these issues. Trikafta means that I can sleep a full 8 hours rather than just 5 or 6 before my chest becomes uncomfortably tight. It means I can finally go to a coffee shop for the morning and just worry about getting my work done, not about how worried everyone else is about whether they'll catch what I have. I can make plans to go out without stopping to worry that CF will get in the way. Now, why am I bringing this up? First, I think it's obviously very relevant to hear the first-person perspectives of people with cystic fibrosis, especially folks who have recently had access to Trikafta, which is having a really positive impact on the lives of many people with cystic fibrosis. But also it's specifically relevant to the ceiling effect discussion because my friend actually did have a relatively high ppFEV1 score prior to taking Trikafta, in part because she had had access to other cystic fibrosis drugs. And so because she had that relatively high ppFEV1 score, which again connects to a relatively high utility, QALY-based utility score, there wasn't a lot of room for her quality of life to improve because she was already rating the value of her life as very similar, approximately equivalent to the life of a person without cystic fibrosis. And so there's a real concern that the QALY is not going to capture these kinds of health improvements because you bump up on that ceiling of 1. And some of the things that may be captured by the use of a condition-specific measure, like the CFQR, will not be reflected in value assessment so long as we are relying on the use of the quality-adjusted life here. Now I'm going to highlight one other concern, and then we will wrap things up. Under QALY-based value assessment, it's very difficult to account for clinical knowledge on differences between different groups of patients, people with disabilities or chronic conditions that are not yet reflected in the research literature. And this is a very particular concern for rare diseases and orphan diseases, in part because you may have a relatively small patient population that's hard to conduct research on that accounts for the many variations that people experience with particular co-occurring conditions or from particular subgroups, in part because there aren't that many people to enroll in clinical trials, and in part because, unfortunately, historically, clinical trials have under-enrolled people with co-occurring disabilities, and also women, people of color, and people from other marginalized groups. And that's very concerning, because knowledge on the differences in how different people respond to the same drug may exist in the clinical world among the group of clinicians that specialize in serving people with cystic fibrosis, or another group of clinicians specializing in serving people with a different diagnosis, but may not exist within the research literature as of yet, and thus does not really get incorporated into the mathematical models that ICER utilizes. One of the things that you'll see is ICER will produce these actually beautifully written reports of sometimes far longer than 100 pages with lots of information. And then there'll be a relatively small section that speaks very directly to the math of how they are calculating the maximum price associated with a particular drug. And unfortunately, the reality is that when it comes to the decisions that your insurance company is going to make about whether or not you have access to a particular medication, the experience of many disability communities is it's really only the math that counts. And so there are some very serious concerns that we are not adequately accounting for the ways in which people with cystic fibrosis, like any group of people, may be different from each other. And so different people may respond differently to the same drugs. And this is something we've already seen from the existing research on cystic fibrosis. If you look at the data on the variation in ppFEV1 in people who are taking Trikafta as compared to placebo, we see a very significant variation. Some people have very dramatic increases in FEV1. Other folks have more modest increases. And the challenge is that if we knew what would predict that variation, then we could just do different subgroup analyses for different groups of people with cystic fibrosis. But often, especially because we really do not enroll in clinical trials first, we often don't enroll a large enough population because it's hard to find people and it's expensive. And second, because we often do not enroll a sufficiently diverse population. Clinical trials often really struggle to identify the reasons behind subgroup variation in the event that they are identifiable in the first place. So again, if we look at different analyses of the effects of different cystic fibrosis medications, and here's a comparison on ppFEV1 of Trikafta versus Symdeko. Symdeko is in light blue, Trikafta is in dark blue, and you can see Trikafta is much more effective than Symdeko in this trial. But there's still a huge variation, both with regards to Symdeko and with regards to Trikafta, in the range of patient responses. Value assessment really often struggles to take into account that information, and particularly QALY-based value assessment, or any form of value assessment that does not make a place for incorporating clinical knowledge, which is especially important for the rare and orphan disease community, really will struggle to take that into account. And that's also going to be the case even if you are using something better than some of the other measures like the even if you are using one of the better measures like the CFQR. So there's a lot of work for us to do in terms of ensuring that people with cystic fibrosis are able to access the medical care that they deserve. Some of that is going to involve engaging in advocacy. This is a press release from the National Council on Disability that recently released a report on the quality adjusted life year and specifically raised these long-standing concerns in the disability rights community that the QALY devalues the lives of people with disabilities. And there's a long history of advocacy at this stage going back almost 30 years of disability rights activists fighting back against proposals to bring the quality adjusted life year to the United States. In the early 1990s, for example, disability rights activists got the federal government to refuse permission to the state of Oregon, which had requested permission to use the QALY in order to allocate healthcare resources in their state. And the reason that the federal government refused Oregon's request to use the QALY was because of at the time, brand new law called the Americans with Disabilities Act. At the time, the position of the federal government was that the quality adjusted life year violated the ADA. Flash forward 18 years later, when a little bit more, 20 years later, I think, when the Affordable Care Act passed. The Affordable Care Act included a specific prohibition on the use of the quality adjusted life year in Medicare or in the newly created Patient-Centered Outcomes Research Institute. And now we are seeing disability rights activists stand up to proposals from ICER and others to once again attempt to bring the QALY to the United States, even though it has been rejected as discriminatory many times before. Given the stakes for the cystic fibrosis community, I know this is an issue that's on many of your minds, and I would really encourage you to look for opportunities to make common cause with the larger disability rights movement. People with disabilities deserve to be treated as equals. People with disabilities deserve to have access to the care that we need in order to survive and thrive. And people with disabilities deserve not to have the value of our lives called into question by the healthcare system. I really encourage you to become engaged on these issues in the coming days, weeks, months, and years. I thank you very much for your time. I can be reached at this email address. And once again, thank you for your advocacy.